We're going to be testing the blood supply of the hand with the Allen's test to test the radial and ulnar artery. We're going to have the patient sitting in the chair, hand, forearm relaxed on the table, occlude the radial and ulnar artery at the wrist, a little bit proximal to the wrist, and have them close and open, make a fist and open for several times. And we see if there's a return of color, and that would mean that there is normal blood flow to the hand. You can do it also one at a time to see if there's a difference. We're going to be assessing the ulnar collateral ligament of the first MCP. With the first MCP Valgus stress test, the patient's going to be relaxed and seated in a chair, arm on the table. We're going to be stabilizing at the proximal part of the MCP, which is the first metacarpal, and I'm going to be moving the proximal phalanx and radially deviate. If there is laxity or pain, then that would indicate a pathology with the ulnar collateral ligament of the first metacarpal phalangeal. We're going to be testing the median nerve when it courses through the carpal tunnel, assessing if they have a carpal tunnel syndrome with the Tinel sign. We simply have the patient sitting in a seat, have their forearm relax over the table. We're going to be tapping with our index and middle finger, palmar side of the wrist. If they notice any neurological signs or symptoms into the thumb, index, and middle finger, that would indicate a positive sign for carpal tunnel syndrome. Another test we can do for carpal tunnel syndrome is the Phalen's test. We're going to have the patient relax in a chair and ask them to bring the dorsal sides of their hands together with their forearm parallel to the ground. We have them hold that position for a minute. We see if there's any neurological signs or symptoms in the median nerve distribution. And if there is, that may be a positive sign for carpal tunnel syndrome. We're going to be testing for the de Quervain's stenosing tenosynovitis with the Finkelstein test. We're going to have the patient sitting in a chair, have their forearm relaxed on the table, have them make a fist with their thumb inside and then tucked in. And then we ask them to ulnar deviate. We can apply a little bit of overpressure. And if there is sharp shooting pain located over the radial aspect of the wrist, that may be positive for stenosing tenosynovitis of the extensor pollicis brevis and abductor pollicis longus. We're going to be testing for extrinsic or intrinsic tightness at the PIP joint. And with the Brunnell-Littler test, we're going to be asking the patient to flex their PIP joint with the MCP joint extended. We're going to measure that and then bring them into MCP flexion and bring their PIP into flexion. If you notice an increase in flexion when you bring that MCP into flexion, then that would indicate tight intrinsic muscles. If there is decrease in flexion when you bring that MCP into flexion, then that may indicate extrinsic tightness. And if there is no change, then that's a joint capsule tightness. We're going to be testing the oblique retinaculum of the DIP joint. We're going to be asking the patient to extend their PIP joint and flex their DIP joint. We measure that, and then we bring their PIP into flexion, and again bring their DIP into flexion and measure that. If there is increased flexion at the DIP joint, then that may indicate tight oblique retinacular ligament. And if not, then if there is no change, then that is a joint capsule restriction. We're going to be checking for an ulnar nerve lesion in the hand by doing the Froments sign. We're going to ask the patient to be seated in a chair and have their hand rested at the edge of the table. And we're going to ask them to bring their pads of their thumb and index finger together. And we're going to ask them to hold this piece of paper in between those fingers, and try to hold the paper there. All right. Positive sign would be a flexion at the IP joint of the thumb. That would indicate that their flexor pollicis longus is compensating because of an ulnar nerve lesion that innervates the flexor pollicis brevis, long head, and also the adductor pollicis. We're going to have the patient in short sitting or seated in a chair, and then ask the patient to bring their tips of their thumb and index finger together. That would be a negative sign. And if their pads of their thumb and index finger touch, that's a positive sign for a anterior interosseous nerve lesion. We're going to be testing the scaphoid with the Watson Scaphoid test. We're going to have the patient seated in a chair, elbow rested on a table. We're going to be feeling for the scaphoid between our index finger and thumb. And then we're going to ulnar deviate and extend the hand, and then radial deviate and flex at the wrist. And if there's any clunking there, that may indicate a positive sign for scaphoid or lunate pathology.